outline the pharmacokinetics of morphine, bupivocaine, and suxamethonium that differ in neonates compared to adults. Briefly describe the clinical implication of those differences. So, um, we're going to go through a couple of more examples in the question. Define. So neonates are the first 28 days of life, and then you go morphine, so an opioid analgesia. Bupivacaine is amide local anesthetic, long acting. Suxamethonium is depolarizing muscle relaxant. Sevoflurane is a volatile anesthetic. Vacuronium is a non-depolarizing muscle relaxant. So you have changes in neonates compared. So there's two options to just give them a quick overview and then go through each drug, which I think you have time for. So A, reduced oral absorption due to delayed gastric emptying, thin skin, so increased topical absorption, increased minute ventilation, which is increased uptake inhaled anesthetics. Then body composition, increased total body weight, reduced fat. Protein binding, decrease albumin and alpha-1 glycoprotein, which reduces protein binding, increases unbound, and also increases clearance. So don't forget that. Cardiac output increase. Our mnemonic, remember, is COPS. So you start with cardiac output increases, lower peak concentration, but quicker onset, time to peak effect. So we've covered CO, which is cardiac output. We've covered the protein binding. We haven't covered pH because it's not relevant here, and we've covered the body composition. Then we go to metabolism. So hepatic metabolism, the immature hepatic, reduced phase 1 and phase 2. Also plasma cholinesterases are reduced. Reduced metabolism of SACs, likely offset of increased VD. And also amide, local anesthetic. Elimination, sorry, not amide, it's esters. Esters and mivacurium. Elimination, reduced renal blood flow, reduced renal clearance, and remember we have in this one is HSP, and then in elimination we have RBT, right? But RBU, not RBT. So renal blood flow, because remember the copium anyway. Renal blood flow is reduced. B is biliary, so we don't really talk about biliary here. And then U is uremia. It's just not to forget. Anyway, PD, you have drug sensitivity. They've only asked for PK factors, by the way. So anyway, immature, but it is important here. Immature respiratory centers, increased sensitivity to sedation. Immature neuromuscular junction, increased sensitivity to neurodepolarizing muscular relaxant. However, likely offset by an increased VD, and you need an increased MAC. And we remember MAC because the mnemonic was asking Siri in the MAC, right? Because that's Siri. Anyway. So let's move on to each drug itself. So morphine, what do you have with morphine? So you have reduced oral absorption, increased uptake of SC. You have distribution, increased VD, so hydrophilic drugs, because of the total body water. Increased sensitivity due to the blood-brain barrier immaturity. Decreased protein binding, AAG. Increased unbound. So you get toxicity. Elimination, you can have decreased M3G and M6G production, so increased duration, because you have a reduced metabolism. Decreased clearance of M3G and M6G, you can get toxicity. Suxamethonium, again, IM might increase the concentration, increase muscle blood flow, increase VD of hydrophilic drugs. So high doses required, and the reason we use hydrophilic when we're talking about here, because we're talking about SUX. Reduced plasma cholinesterase, a balanced effect. And metabolism and elimination, there's not really anything, it's mainly the plasma esterases. Sevoflurane, increased FA-FI, increased ventilation, increased speed of onset. Reduced fat, which means reduced blood gas, solubility, that means increased onset, because the sevoflurane doesn't get stuck in the fat in terms of duration, but it increases the onset. Also increases cardiac output, which reduces the speed of FI rise, but this is offset by the increased minute ventilation and FRC ratio. And then metabolism, so increased minute ventilation and FRC, increased washout, increased speed of washout, and compensated by increased cardiac output. So also MAC is higher in neonates versus adult. MAC minimum alveolar concentration, I guess, requirement. So remember, increased cardiac output, for it depends on the duration obviously, but a long duration and increased cardiac output will slow down the onset, and when you have an offset, it would also, it would technically increase the offset, but if you have an increased cardiac output, you'll have a slower offset because you have more into the blood, and rather than the lungs. So that's why it's compensated by an increased cardiac output in terms of the speed of washout is quicker because of the minute ventilation, but an increased cardiac output, obviously depending on the duration. Then bupivocaine, increased absorption, subcut, increased risk of toxicity, and then drugs decrease unionized fraction due to decreasing plasma pH, increased duration of the effect, and reduced protein binding, risk of toxicity. Oh, so the plasma heat pH is important. Metabolism, decreased metabolites, decreased elimination, risk of toxicity. Vecuronium, increased VD of hydrophilic drugs, increased doses required. Increased cardiac output, reduced peak concentration, faster time to peak effect. Metabolic and elimination, increased hepatic and renal clearance, increased duration of the effect. Neuromuscular junction immature, hence increased sensitivity, however counteracted by the increased VD. Because you have an increased volume of distribution, then the drug will be gone quicker. So increased volume of distribution, then you need more of the drug, but you have increased duration.